This really got started. I have to thank, you can stand up. Come on, stand up. Okay. Hi. She attended one of my conferences. She says, oh, you got to come and talk for this one here. So I said, okay, I'd be more than happy to. And then I got invited. So thank you very much for inviting me. I'm sorry? Oh. Please. So we're going to talk about enteral access. A lot of patients require tube feedings, people that have motility problems, et cetera. Typically, when do we decide to put a patient on tube feedings? It's when they can't take enough by mouth, and we need to assist them. This is going to be supplemental feeding for them. And to me, I like to think, I'm not a good chess player, but I do play checkers. And you got to sort of think a couple of steps ahead when you're making your move. So you have to decide, is it going to be short-term or long-term? If it's short-term, maybe you just need to put in a nasogastric tube or a nasojejunal tube. If it's a ventilated patient, you might want to use the oral gastric route. And unfortunately, a lot of people like to attach the feeding tube to the endotracheal tube. Not a good idea, because what happens when they extubate the patient, they extubate the GI tract before determining whether they can eat on their own. Obviously, they're breathing on their own, but so I try to get them to think different systems. And if it's going to be long-term, you got to think about something that goes through the skin directly into the GI tract. Next slide. You can just push enter. You can just do this. Just do that. Okay, that should. There we go. Okay. So for most patients, they're going to have some type of nasoenteral tube. But if you're thinking ahead, just like playing checkers, okay, if you know it's going to be more than 4 to 6 weeks, think about a percutaneous tube. And sometimes you can't get the tube in someone's nose. Not everyone has a nose like mine where it's easy to get it in. Other people, they have injury, trauma, facial fractures, all sorts of things that you can't get it in. I usually get called for the ones that no one else can put in, and I get lucky, basically. Okay, so I'll do it. But sometimes it's difficult, especially if the patient's not with it, they can't swallow, it makes it a little bit harder. So I take my time, but I know my limitations, and sometimes I need help either from an endoscopist or the ENT person to help me to do it. And some misconceptions. Just because you have an endotracheal tube in place, that doesn't necessarily protect you from the tube going into the lung. And it's my feeling that because the tube is there, tubes like each other, so they want to actually follow the same route and go into the lung. So, and although this was in the past with the big hoses that they used to use, the Salem sump, et cetera, which is really a suctioning tube, bacterial sinusitis is something that I don't see very commonly. Next, please. Okay. So I try to keep it small if I can. I've never used an 18 French nasogastric tube, 14 typically or 12 in adults. They have smaller ones, 8 to 12 French. Usually those are the longer ones. Something I have never been able to figure out, they make the tube longer and they make it thinner.